All right, our last group of the quarter, your Unit 11 drugs. And I am sure many of you are happy to see there are only 7. Feels like a vacation whenever you only have 7 drugs to learn after you've been learning 15 or more drugs per week. So here we're just kind of filling in all of the drugs that we looked at as we went along the quarter, but they never really fit in, so we just kind of stuck them here in Unit 11 so that you could make sure and have them. So we have first off our epoetin alpha and filgrastim. So these are our 2 biologic response modifiers. What these drugs do, epoetin alpha takes and increases our red blood cells. So if we have someone who is on chemotherapy and they need their red blood cells replaced, this is the drug that they will get, and it comes by injection. This drug can also be given to your patients who have renal failure because they are not making the erythropoietin that is normally made by the kidneys to stimulate red blood cell production. So this drug can also be used for them. One thing you want to think about is if we're increasing red blood cells, this is how it helps me remember the issues associated with it, is that we can end up causing hypertension, we can cause them to have too many blood cells, they can end up having a stroke, they can have injection site pain. So, some of the bigger issues associated with these drugs are really having to do with the increased blood cells. They can also end up having some edema with this drug as well. With filgrastim, with this one, what we're doing is increasing the white blood cell count. So as we are giving, again, chemotherapy is usually one of the most common reasons a patient's white blood cells are killed, and we need to help replace it. So filgrastim is often given daily for 10 days or 14 days after a round of chemotherapy. If you think about chemotherapy, we want our patient to get all of their doses of medication. We don't want that their blood cells are off to be the reason they aren't getting it. So this is why we can use these drugs to help. Now with filgrastim, we have this low white blood cell count, puts them at a very high risk for infection. And actually that's what your side effects look like, are infection. They just start feeling good, malaise, tired. One of the biggest issues I've heard from people is bone pain. So to treat this bone pain, we'll normally use an NSAID to help treat it, and if that isn't working, the doctor may end up having to order an opioid to take care of that. But we have to be really careful with this patient with the low white blood cell count. They're normally, if they're in the hospital, they're on reverse isolation. They don't get the fresh flowers, the fresh fruit, the fresh vegetables, everything is canned because they're just at such a high risk of getting an infection. One of the other things, and I'm sorry I forgot to mention it with epoetin alpha, we're going to be watching the hematocrit and hemoglobin. If we get up to 11, 12, they may not need the medication. That is something that I would call the doctor on just to be sure that they still want us to give the medication for them because their RBCs are increasing, and we know that through the labs. Okay, moving on to the women's medication. Here, the drug you have is conjugated estrogen, and we give this as an estrogen replacement normally to perimenopausal and postmenopausal women. It is normally not prescribed for longer than 5 years because it has such a high risk of causing cancers in women. If a person has a history of breast cancer or uterine cancer, normally we will not even use the estrogen because the fear is that the cancer is fed by this estrogen, and we do not want it to happen. We don't want it to be fed. So then we'll use something else to try to help the patient deal with the symptoms of low estrogen. So again, this one is used just as a replacement. A lot of the side effects and adverse reactions are similar to perimenstrual, the irritability, the sweats, the breast tenderness, just it's very similar to that perimenstrual type problem. Okay, looking at men's, we'll look at testosterone. And for the men with testosterone that we are doing the testosterone with, here we need to be careful of the liver because the testosterone can be hepatotoxic if it's given in too high of a dose. So we have to pay attention to their liver. With this one, it causes more behavioral changes that make the men more aggressive, more angry. So that is something that we have to really pay attention to because we don't want to over testosterone the person and make them so angry that they aren't able to cope with day-to-day issues without, going crazy. But really the big thing is the liver that we have to pay attention to for the testosterone. Also, if your patient has had a history of prostate cancer, testosterone is usually not given to that patient because it, again, just like with the women's, this can feed that prostate cancer. Our biphosphonate, this is a drug that we use to treat osteoporosis. The drug that we use is alendronate. And what happens is it goes in, it's the phosphorus that pushes the calcium back into the bone so that we have the bones repairing and, getting all of those little holes hopefully filled in or preventing them from even occurring. This drug is given once a week and it's given by pill. Now, because this drug is so hard on the esophagus, the patient, when they take it, has to be on an empty stomach, full glass of water, and then they have to sit up for at least 30 minutes. So if your patient is unable to drink a full glass of water or sit or stand for 30 minutes, they may have to go on to one of the other drugs that's given IV. So just something to think about with these, and we're hoping that this will help fill in the bone, prevent them from losing calcium from the bone. All right, our phosphodiesterase inhibitor, this one is sildenafil. So this drug we use for erectile dysfunction. The thing is, though, is you could see women on it because it was originally made to take care of pulmonary hypertension and hypertension. And you'll still see it used for that. But then it had a side effect that they were like, oh boy, we can make so much more money here. And that's what ended up happening. The thing is, though, is this drug can lower the blood pressure. So we have to be sure our patient understands that. Cannot be given with nitrates. That means around the time that this is working, they cannot take a nitrate. The two of them together can drop out the blood pressure and we may not be able to get it back. So just remember that nitro is contraindicated with sildenafil. We have to be careful if the patient is on other medications that lower their blood pressure as well. Last drug on the list is tamsulosin. This one is an alpha blocker. We did this drug in Unit 6, Prazosin. This one can also lower the blood pressure because we use Prazosin as an antihypertensive. But with tamsulosin, its primary use is to help shrink the prostate so that a man who has benign prostatic hypertrophy has an easier time starting their flow and continuing their flow. But don't forget, it can also lower the blood pressure. So there are your drugs for the whole quarter. Great job making it through this quarter. And if you have any questions, let us know.